So if we look at the pathophysiology of stroke, this pathophysiology applies to any vascular problem. So if you look at the problem with the blood vessels, so stroke is basically problem in the blood vessels in the brain. Okay, so it's a problem in the blood vessels. So how many layers we have got in blood vessels? 3, very good. So what are the layers? Tunica intima. So what are the parts of the tunica intima? So basement membrane, endothelial cells, and anything else? So there is a slimy layer over the endothelium. What is that called? You have to read about that. So there is a slimy layer which is, very, for last 4 or 5 years, it's been discovered, or we know about it. Okay. So that's the endothelial cells or the tunica intima. What is the middle layer? Tunica media. What has it got? Huh? Yeah, smooth muscles and connective tissue. And what has got adventitia got? The final layer, tunica intima media adventitia. What has adventitia got? Mainly fibrous tissue. Okay. So these are the layers of the blood vessels. In case of ischemic stroke, which layer is most commonly affected? For the ischemic stroke, to produce clot, which layer is most important out of these 3? Tunica intima, the endothelial cells, okay, and the layer. So that is the most important. Now, first of all, we will see our blood vessels or blood is prone to form clot. How is it prevented? Okay, if you know that, then you can understand in each of the pathophysiology how it is affected. Okay, so let's concentrate on the tunica intima. So normally the endothelial cells has got an antiplatelet activity. So it has got antiplatelet activity, anticoagulant activity, and anti-inflammatory activity. Okay, all endothelial cells has got this following function. So let's first of all see how does it prevent platelet from sticking to it. Okay, platelet is procoagulant. If you allow the platelet to stick to it, what will happen? It will form clot, thrombus, and that's where the risk of heart attack and stroke will go up. So what is the normal mechanism by which it prevents? Okay, so let's draw something. So this is our happy platelet, very happy, very friendly platelet normally. Okay. Happy platelet. Want to make friendship with the endothelial cells. Do you think endothelial cell will allow that to become very friendly with the platelet? Why?
Because it hasn't upregulated the receptors.
So, no, in general term, they won't want, because otherwise clot and the body will die. They don't want that. Okay. So how do they prevent now? Charlotte, tell me, what are the things which can prevent?
By not having the receptors upregulated? I don't know.
So normally, so as we said that there is a slimy layer. So if a surface is slippery, do you think platelet can stick?
No.
What else? Normally, platelets are negatively charged. And normal healthy endotheliums are negatively charged. So do you think they will stick? What else? They produce some chemicals as well, which actively stop. So what are the chemicals which are produced by the endothelial cell which prevent platelet adhesion followed by aggregation? Anyone? They secrete three important chemicals: nitric oxide, ADP, D-phosphorylase, and prostacyclin. So these are the common chemicals which are secreted by the endothelial cells, and that's why our happy platelet become very unhappy. And they are not sticking to the endothelial cells. Crying. Okay, happy platelet cannot. So this is the normal function of the endothelial cells, thereby they causes antiplatelet activity. Is that clear up to this? Now, normal endothelial cells has got anticoagulant activity as well. So how does it perform that?
It acts as a physical barrier, so it's going thromboxane activate.
Okay, it has a tight junction, physical barrier which is preventing. Very good. What else? It expresses what is called heparin-like substance, heparin sulfate. Okay, it expresses heparin. What does heparin do?
Prevents the conversion of factor 10 into factor 2.
So what does it do? It binds with what? Heparin binds with what? And it forms a complex. It binds with antithrombin 3. Where do you get antithrombin 3 from? It is secreted from liver. Goes into the circulation, it binds with this complex now inhibit what?
Factor 2 and 10 synthesis.
So factor 2A, 9A, 10A, 11A, and thereby prevent coagulation. Is that clear? Okay. It also expresses thrombomodulin. What does it do? What does it bind with, do you think, thrombomodulin? Thrombomodulin. What will it bind with?
Thromboxane.
Yeah, thrombin. Okay, activated thrombin, factor 2A. So now, Emily, okay?
Yeah, you've got a phone call that keeps coming through.
Oh, just ignore.
Okay.
Oh, what is that? Is it any number?
07939. I don't know, it's rung 3 times now.
Leave it.
Okay.
Just remind me after I finish.
Okay.
So, thrombomodulin, what does it bind with? Thrombin. And this complex, along with protein C and S, together they form a complex. What do they inhibit?
The thromboxane binds the platelets to activate.
So what do they inhibit? Which clotting factor? So obviously thrombin is bind, so it is modulated, so it's already inhibited. On top of that, it inhibits factor 5A and factor 8A and thereby prevent coagulation. Is that clear? Okay. It also expresses tissue factor pathway inhibitor. Tissue factor pathway inhibitor, which essentially stops activated factor 7 from stimulating the pathway. Okay, what else? They express tissue plasminogen activator. What does it do? Tissue plasminogen activator.
It breaks down fibrinogen into fibrin.
So it converts plasminogen to plasmin. What does the plasmin do?
To factor 13.
Plasmin breaks down the fibrin to fibrin degradation product and thereby it dissolves the clot. Because essentially clots are fibrin mesh where the cells are trapped. If you break down the fibrin, what will happen to the mesh? Gone, cells are freed, you get the dissolve. And that's why we use the tissue plasminogen activator artificially, altiplase, tenecteplase, to dissolve the clot in stroke. Okay, so that's the mechanism. Okay, so that's the anticoagulant activity. And what is the anti-inflammatory activity? For example, nitric oxide, various interleukins also helps in anti-inflammation. Now, how can you keep the endothelial cells healthy? How can you keep the endothelial cells healthy? So, normal streamlined blood flow. Normal streamlined blood flow, when they rub, that helps to produce all the chemicals which are responsible for giving antiplatelet, anticoagulant, anti-inflammatory activity. Now, remember, what happens in hypertension?
Shear forces.
So, normal streamlined blood flow is replaced by increased lateral, increased lateral pressure. That causes endothelial dysfunction. All the antiplatelet, anticoagulant, anti-inflammatory activity is compromised. Thereby, you are more prone to form atherosclerosis, more prone to form clot. Okay. What happens in atrial fibrillation? Same thing. Streamlined blood flow is replaced by irregular blood flow. More chance of clot. What happens in smoking?
Services.
Yeah, it damages because of the chemical and thereby cause all the problem. What happens in diabetes? Excess glucose damage the endothelium, cause increased risk of atherosclerosis, thrombus, and that is the prime factor. If you go on each of them, you can explain. On top of that, what did I tell? What is the primary problem? Hyperinsulinemia because of metabolic syndrome. Insulin also damages the endothelial cells. It causes endothelial dysfunction, excess insulin. And that's the key driving factor. Is that clear? That's the mechanism of ischemic stroke. Now, when it comes to hemorrhagic stroke, which layer is more important out of these three? Media more, followed by adventitia rather than endothelial cells. Why? I've got some beautiful example. Now imagine this is the media. So if you think of rubber band, okay? If you stretch it to the limit, I'm not doing it because it will if you stretch it to the limit before it snaps and then release it, what will happen to the rubber band?
Snaps.
Stretch.
So it loses its elasticity and thereby the thing gets, this will be like this. So next time it is easier to snap because the whole rubber band is weak now. Okay. Similar thing happens in hypertension. What's happening? Because of lateral pressure, this medial layer is damaged When they are damaged, they are replaced by hyaline-like material, which makes it weak, and thereby it is more prone to rupture. What happens in cerebral amyloid angiopathy? Deposition of amyloid in the medial layer, still in the medial layer, okay, thereby making it weak, and that's why it rupture. Okay, one of the important thing for hypertension, which group of blood vessels are more affected? Which group of blood vessels are more affected?
Veins.
Hmm?
Veins.
Not vein, it is all we are talking about artery, no question of vein. So more blood vessels which require more pressure naturally to deliver the blood. So which group of blood vessels will require more pressure normally? Not great vessels, smaller, deeper perforating vessels, what we call lacunar vessels. Parts of the brain, for example, internal capsule, basal ganglion, thalamus, corpus callosum, deeper part of the pons, deeper part of the cerebellum. These are supplied by lacunar vessels, which have normally got high pressure. And if you have hypertension, it's even more. So what will happen? These vessels are specifically more affected in hypertension. So thereby, when there is a bleed, if you see in this location, you suspect hypertension as the important cause. Whereas in cerebral amyloid angiopathy, for reason what is unknown, it affects superficial vessels like supplying the frontal lobe, parietal lobe, occipital lobe, temporal lobe, insular cortex, then superficial part of the cerebellum. So in cerebral amyloid angiopathy, distribution of bleed is in those locations. Is that clear? So that is in short the pathophysiology of stroke. Emily, you can stop now.